Hi again, everybody. I'm here with Dr. Bob Rothbard from Rancho, Cucamonga Optometric Center. And today, hi Bob.
Julie, how are you today?
I am so great.
Good.
Today we're going to talk about contact lenses. And I'm very excited because I really don't know a lot about contact lenses. But you gave me some idea that maybe there's a certain age-appropriate thing, certain ages contacts are better for, or?
Julie, I fit individuals with contacts myself starting at the age of 4. And the oldest person who had never worn contacts before, and one of them was probably in her late 70s.
Oh, wow. So a real broad range of ages.
And even more so than that, ones whom I wouldn't fit are little kids or infants who've had cataract surgery removed, and you have to fit them with a contact lens. You cannot fit them with glasses.
Oh, wow.
And I don't do that.
Because little babies won't wear glasses. They'll just keep knocking
also,
them off their face?
For reasons that we're going to discuss a little bit later, you can't fit the kid with glasses because one image will be a lot bigger than the other.
Oh, do you want to talk about that right now? I believe you have your handy-dandy lens
there.
There.
Well, one of the things that we've described or described to patients is what's called medically necessary contact lenses. Medically necessary means you can do something with contact lenses that you cannot do with glasses.
Oh, what's that?
And basically, if you have a big difference between the two eyes, one image is going to be seen bigger than the other if that person is wearing glasses.
Really?
And there's a big difference between the two eyes.
Oh, but not with contacts.
Not with contacts because the contact lens is right on the eye. Therefore, you don't get minification or magnification depending on what the prescription is.
I didn't even know there was a word, minification.
Well,
I'm so happy to learn that word.
And you're the one who could spell terpsichorean,
so
I tell you so.
Minification up and down the street after
exactly.
this.
So anyway.
I'm sorry, I cut you off.
Right. So when you want to prescribe this, if the person has one eye that's a lot bigger than the other, or the image is a lot bigger than the other, the brain cannot bring those two images together. Therefore, the eyes will not team together, and the person will either see double or totally suppress out. In other words, will totally ignore the image from that eye.
Oh, I can imagine, based on our other videos.
Exactly.
That would be important. Well, that's fascinating. That's really cool. And what are some of the advances that have happened in contact lenses in recent years?
Well, the biggest advances have been dealing with the fact that you're getting contact lenses that let through a lot more oxygen.
Oh,
and
that's
therefore
great.
They breathe better. Therefore, you have a lot less chance of eye infection, or the eyes drying out at the end of the day, or the fact that you can sleep in them a lot more easily.
And the eye is just healthier overall, I would imagine.
Big differences where we used to see blood vessels forming in the eye due to a lack of oxygen, which is the technical term is neovascularization. We see a lot less of that with the newer contact lenses, and a lot of them are composed of silicone.
Oh, really?
Silicone-based contact lenses.
Wow, that's fascinating.
The other big change that's occurring is dealing with the over 40 set of individuals who don't want to wear reading glasses over their contact lenses. Now, we used to fit those individuals with what was called monovision, one eye for reading and one eye for distance. And believe it or not, you can't do that with glasses, but you can do it with contact lenses.
Oh,
however, some individuals could never get used to that.
I can imagine. And
so that didn't work. But the bifocal contact lenses or the multifocal contact lenses that have come out, it's still not an exact science. Sometimes I figure it's an art. At least we could fit 60 to 70% of the patients in those.
So they're gradated like a bifocal would be?
Well, you really figure out what's interesting about this is the fact that the whole center of the lens can be for distance, and the whole peripheral part could be for reading, or vice versa. The whole peripheral part could be for distance, and the whole center for reading. And somehow the brain can figure it out.
Wow.
And it seems to work fairly well. And with some people, it's really neat because a person who wears a bifocal, when they're looking at the top shelf at a store, bifocal and glasses, would have to read like this, tilt their head back and get their head underneath the bifocal.
Yeah, to read from the bottom.
With these lenses, it seems to work pretty well.
Wow.
And another thing that I've noticed that's really neat, the higher the prescription that the person has, the better contact lenses work. And especially as the patient gets older and the individuals are farsighted, in other words, individuals who used to be able to see distance, can't see reading, then as they get older, everything starts receding out, and God, they can't see anything
Near
close
or
up,
far.
middle, or distance anymore. The farsighted individuals, for those people, contact lenses are almost a godsend. It really works out really well for these people.
That's
for
wonderful.
these patients.
That's terrific.
So, and we show it to people. Heck, I got patients who come look at glasses, and they don't know what the heck they're trying on. Because they're farsighted. They can't see anything close up. Or they bring somebody, or now with technology, they can just snap it on their iPhone and take a look at themselves. But in some of these people, we actually put contact lenses in their eyes so they can actually see what they're looking at.
Wow.
So that's been a pretty neat thing.
That is. That sounds like they are a godsend. They're really wonderful.
And they work out pretty well. It used to be you couldn't fit individuals for astigmatism. They've come out with better and better lenses over the last 20 years for that. So that's been a pretty good thing also.
And what is astigmatism?
Stigmatism is an interesting word whose root is the word stigma, which means point. Point. Astigma, no point. So no point focus. Some people consider it the eyes are at a round and so forth. But what it means is that if you were looking at a clock dial, the lines going up and down, left and right, diagonally, if you have astigmatism, no matter where you hold that target, none of those lines are going to come into focus.
Converge ever.
Or when there is no astigmatism, there's going to be one point where all of them come into the same focus and so forth. And it's like if you were to look at the letter E. When you have an astigmatism, it could be that you look at the vertical line and it's a lot sharper focus than the lines horizontally.
How interesting. Wow.
So the lenses for that are getting better. Also, it's interesting in the fact when you first prescribe astigmatism in the form of glasses to an individual, they'll think of the floor. Hey, the floor's coming up at me, the walls are bowed out and so forth. You don't get any of those effects with contact lenses, basically. It's a lot less. Because again, the correction is on the eye. You don't get any minification or magnification effect with the contact lenses. So that's a really neat thing.
That is. Okay, one other thing, Bob. I remember there were hard contacts and soft contacts. Do they still have that?
Julie, of course, they have the soft. The hards were the first ones out. They were developed so far long ago. They used to have ones that were made out of glass, maybe over 100 years ago. But basically, when you think of contact lenses, they basically came out in the 50s. But one of the problems with the hard contact lenses is the fact that they didn't breathe. They were not gas permeable.
Oh, right.
And we used to get a couple of our patients back in the bad old days of contact lenses who would actually sleep in those things. And that was a good trip down to the emergency ward because the eye was like suffocated.
And are they kind of glued to your eye?
They're stuck. And like any living tissue that doesn't get oxygen, there's problems.
Oh my gosh, that sounds horrible.
In the late 70s, they started to come out with newer materials, basically a lot of them silicone, which breathe a lot better.
Wow.
But the problem with hard contact lenses initially is the fact that you feel them a lot more, not because they're hard, but because they're small. One's like 9.5 millimeters versus 14 millimeters, 14.5.
In diameter?
In diameter.
Oh.
So when you had a small lens, every time you blinked, the lid would hit the lens, and that's why you would feel it. Whereas a soft lens is a lot bigger, so the edge is way past where the lid would come down. It's already underneath the lid.
Oh, interesting.
So that's one of the reasons for differences in comfort. For some individuals, a hard contact lens is all the difference in the world. There are certain diseases of the eyes where there's a deformity in the front surface. One of the diseases, keratoconus.
And that hard surface
creates a new front surface. Whereas with keratoconus, which is a progressive degeneration of the cornea, it becomes thinner and more irregularly shaped. You can only correct that with a hard lens. Also, patients who started with hard lenses, very hard to get them to shift over the soft.
They're happy with them.
Exactly. But one of the things which a disadvantage of a hard is the fact that since they are smaller, they could dislodge in sports, and also dust can get underneath them a lot more easily, leading to discomfort.
Oh, I see. Well, that's very informative. Well,
Good.
we've learned a lot about contact lenses. Thank you, Bob.
You're welcome, Julie.